Good morning, everyone. My name is Tim Moore. Welcome to our ongoing webinar series of solution sets dedicated to the healthcare marketplace. Today, we have a real special treat. We have Michael Laidlaw, who is a expert in patient access, formerly of a large healthcare organization in California. And we have Dinesh Gambhir, who is CEO of First Outcomes. Artificial intelligence, augmented intelligence is a big buzzword in the healthcare space. And today you're going to be pleased to see interactions of a real-time workable tool set to help with all those instances where humans can't and bots, robots, artificial intelligence can. Also, if you are going to be at HFMA ANI in Minneapolis, November 8th through the 10th, there'll be a booth there. You can meet Dinesh in person. With that, let me turn it over to them. They'll do their intros and their bios and backgrounds, and I think you'll find this very enjoyable.
Hi, my name is Mike Laidlaw, and we are going to be discussing artificial intelligence for healthcare operations. To give you a little background about me, I've been working with hospitals and medical groups for just over 50 years. And fortunately, I've been able to retire. One of the things that blends very nicely with AI is Six Sigma and the concepts of lean, which is a repetitive process that does not change. Most recently, I worked with Sutter Health for the past 12 years and a variety of different positions. And prior to that, I worked with Alameda County Health Systems. So for today, I'd like to introduce our primary speaker, Dinesh Gambhir, who will lead us through the discussion.
Hi, folks. Interesting fact about me. I actually grew up in Canada in the province of Newfoundland. Newfoundland is actually the last piece of land before the Atlantic Ocean. As you can see in this promotional slide from the province, any more east, you'd be west, right? That is, there is no more east of North America. So I have a bachelor's in computer engineering from Concordia University. It was one of the first computer engineering programs in Canada. Came to the States and did a doctorate in computer science from NYU. I worked for quite a number of consulting companies, Ernst & Young Consulting, Deloitte Consulting, rose up through the ranks. But what got me here was I was tapped by a friend to be a co-founder of Navitar. Navitar is a SaaS provider for hedge funds and venture capital companies. And then I was co-founded Health Expense. At Health Expense, we automated flexible spending accounts and healthcare spending account payments. After leaving Health Expense, my ideas were all around the Silicon Valley idea that healthcare is really about the phone. Everything should be available on the phone. And I think, Mike, you'll agree that most folks, even now, when they think about technology and healthcare, they think about the phone. Would that be correct?
Pretty much everyone uses a phone nowadays. At least in California, you can't go anywhere without somebody having a smartphone.
Well, that's what I thought until I started working with our first client. So Long Island Select Healthcare is a federally qualified healthcare center. And to understand what that means, I'm showing you the figure that they have 55 providers, but only 85,000 visits a year. What that means is they're spending close to 1 hour with many patients per appointment. And the reason why is the folks who come to them are the folks who really need a lot of help, intellectually disabled folks, folks facing really bad problems at home, a lot of psychiatric patients. Many of their patients are on Medicaid or older and on Medicare or are disabled on both Medicaid and Medicare. And working with Long Island Select Healthcare, what I found that while we were using AI to improve their healthcare operations, we came upon a basic fact. It's not about the smartphones. Part of Long Island is farming communities. In fact, most of the East End is farming. And 20% of the people in those rural areas don't have a smartphone. If you're on Medicaid, if you have income less than 30,000, which is almost high in some parts of America, a quarter of you do not have a smartphone. And if you're over 65, almost 60% don't have a smartphone. So when we think of the people who need the most help, the people who see the doctors the most often, the seniors, the people who have less money so their health suffers, we come to the point that they don't have smartphones. And you'll say, that's not me. But Mike, I know you've worked a lot at Sutter Health. I think you'll agree with this statement, right? Most people, when they need help, when they need to access care, is done by a phone. Would you agree with me, Mike?
Well, interestingly enough, the 88% is a good number, but also, even though health systems have their own internal way for people to make appointments, all you can do is request an appointment. You can't actually make it. Someone has to call you back. So you're making a call to them, or they're making a call to you, but you're requesting it online, but there's still that human interaction.
And Mike, that's just not fair. So out of our experience at Long Island Select Healthcare, our mission became clear. No patient left behind. That is, whether you have access to a computer, a smartphone, or a flip phone, we'll always make sure you can access care when you need it 24/7. And when we look for people to work with, distribution partners, SmartSource stuck out because of their agreement in our mission. SmartSource says, yes, wherever we take you, we will make sure our partnerships, our clients, we're all aligned. This is about getting care to the people who need it the most, especially proactive, preventive care.
So Dinesh, how do you do this? And can you give us more as it relates to digital employees?
Yes, thank you, Mike. So digital employee is another word for the AI we use. So here you see my funny little icon of digital employee and a pointer showing they do something. So what do? First thing is they're able to talk, text, and even see a person or a form. Remember, we give them the same capabilities that a person has. So you can talk to them on the phone. And what they'll do, this is their limitation, but they're really great thing, is they'll repeat the same process over and over again, never making an error. So we don't want, it's very hard for humans to keep on in a high pressure, say, scheduling environment, scheduling appointments without making an error. A digital employee will do that. Same with the follow-up, making sure you're doing well after an operation. The difference between a digital employee and a real employee is scalability. So if on Monday morning, 9 a.m., your medical office gets 1 million calls, and I'm being facetious, But say you get 1,000 calls, 1,000 digital employees will be available to answer those calls. So people will not wait. They will always have access to a digital employee to help them. And if it's 2 in the morning, the digital employee will still be there to set up an appointment first thing in the morning, or to set up a telephonic or a televideo visit so that the patient can be taken care of.
So one of the questions I have, Dinesh, is I know in California and actually all over the country, we have people speaking different languages from different countries. And how is that managed using the digital employee?
So, Mike, that's a great question. And first, I want to talk about how it's managed in English, and then let's talk about how it's managed in multiple languages. So let's go and actually listen to a digital employee answering the phone in English so you can understand how that happens. Would that be okay?
Yes, that would be great.
Okay. So 4 examples of digital employees that First Outcomes deploys. You'll see one of them is a scheduler, and I want you to listen to how they work. But we also have patient navigator digital employees, care coordinator digital employees, and post-op nurse digital employees. But let's have a listen to the scheduler.
I need to make an appointment.
Welcome, John Smith. You have been verified from your caller ID. This is the virtual assistant for Long Island Select Healthcare. I can now help you with your appointment. If you want to book a new appointment, say new appointment. Or if you want to cancel or change your appointment, you can say cancel my appointment or change appointment. I didn't get that. Please speak again.
New appointment.
Sure, I can help you make a new appointment with the provider you recently consulted. Your recent appointments are with provider Mason Cozy. Do you want to make an appointment with Mason Cozy? Please say yes to confirm or else no.
Yes.
Great. The first available appointment slot for provider Mason Cozy is on Monday, June 7th, 2021, 9 a.m. Does this work for you? Please say yes to confirm or else no to change your slot.
Yes, I confirm.
Perfect. Your appointment with provider Mason Cozy for Monday, June 7th, 2021, 9 a.m. booked. Thank you. Bye.
So, Mike, that was an example. I apologize. A little bit of the sound quality wasn't good at the beginning, but that was an actual recording of one of our employees at First Outcomes talking to a digital scheduler. And you see how easy it was for the scheduler to actually set up the appointment.
I think as you and I have discussed in the past, that was part of the piece at the very end of my career that we were missing that would have provided a really good opportunity to close out the scheduling, rescheduling, cancellation process without having to use a number of human intervention, whereas you would have a digital employee that would be able to provide that service for us.
And Mike, that's the point. Why are we having people do robotic work when they should be, the digital employees will hand off to the scheduler things which are more difficult. For example, if somebody just got discharged from a hospital or an ED, they need to come in immediately. And a digital scheduler might not be able to find the appointment for them. So it'll hand it off to a human scheduler so the human scheduler can take care of that difficult task. What our digital employees do is they actually take care of what I call the boring, repetitive stuff, and the employees are actually upskilled to take care of real care problems. And that is a really great thing for the employees.
I think one of the operational pieces that I see with this is that, as you had indicated in an earlier slide, is that there's consistency forever in terms of the order and sequencing of how things are done. And you will see in many places that after a while, I get tired of doing something a certain way, so I just make it my own way of doing it. This way with the bots, as you said, it may seem somewhat boring, but it's consistent in the manner in which it's being executed.
And it's consistent across languages. So coming back to the question you asked, how do we deal with different languages? So the bots can be trained to speak multiple languages, right? To set up appointments and to listen for key, what we call intents. So an intent, when we speak, we want something to be done. So the bots are able to understand the intent in many languages, not just Spanish. If you want Creole because you have a large Haitian population you're taking care of, we can do that. And we do that effectively because the bots never get tired. And the bots are smart enough. If somebody says, I want to speak to a human or to a representative, or the bots detect that there's a problem because somebody says, I need help, they'll pass it off to a human so that that help can be given. Now, if that help is not available because the local center does not have those folks able to speak the language, then the bot will actually hand it off to a remote center where people who speak that language are available. So we empower each of the local practices with far more skills in terms of talking to patients than they would normally have. We are additive. We do great things for the practices.
So I got a couple of questions, which are, I think, part of the whole process. One of the things I'm a little bit intrigued by is the idea that you have 8 different bots available. Can you give us an idea why there are 8 and what they do that's unique and important?
So you see 4 here. There are another 4 bots, and each of them have to do with certain parts of patient operations. So one part of patient operations we're not showing you here is actually marketing ops. Many practices get requests and information from websites. They have to cut and paste, for example, insurance cards into their EMR. We take care of that. In terms of patient navigation, what we show here is only part of it. When a doctor writes in their note that they're giving a referral to a patient, then our referral digital employee, and again, sometimes the word bot is used, that's okay. Digital employee or bot is equivalent to us. So what we call our referral bot, our referral digital employee, will read the doctor's notes and then follow up with the patient to make sure they were able to get an appointment with the doctor that they needed to see, the specialist. And if not, then that bot will actually escalate to a human patient navigator so that the appointment is set up. So those are 2 examples. Everywhere there is an operation, we take care of it in terms of practice ops. What we don't touch is revenue cycle. And the reason we don't touch revenue cycle is because there are much better solutions out there. Olive, for example, is a public company that really dominates. Let me correct them. They're a private company that dominates this field.
Interesting. So going back, just generally speaking, is it appears that you've developed a process that can have multiple uses across multiple different types of platforms. But I do think that the one market that you're really capturing, which no one else is, quite frankly, is that market of people who are either underinsured, uninsured, or in that gap, if you will, of not having access to technology, either because they don't want it or because it's not available to them. And that, from your previous examples, shows how you can address all the issues to this particular patient population.
Mike, you hit on two great points. So one we haven't talked about is we basically integrate with almost any EMR and practice management system out there. For the technical guys out there, HL7, HL7 Fire, and if we need to do RPA. So lots of acronyms, but the tech guys will understand those as key ways to work with EMR systems. And we support every method out there. We've been successful in doing that. Second thing, as you said, Mike, what really makes this different is our bots, because they're available 24/7, there's no waiting. If you're in pain, hitting the smartphone is not the thing you want to do. You just want to call and talk to somebody so that you get access to care. And our technology lets you do that. And it doesn't matter if you're in the middle of nowhere without an internet signal, you just have to call and we'll make sure you get the care. And it's the same thing. When you go home after an operation, our post-op nurse digital employee will call and make sure you're doing well. And if things are not going well, then you'll be transferred immediately to a triage nurse so things can be addressed. And we're really proud of this. That's why I said this is our mission. We do great things for practices. We work with their EMRs. We allow them to have more capacity. We lower costs. In fact, we calculated, and you can probably tell, you can validate my numbers, Mike. We calculated that for a practice seeing 100,000 patients, we're saving about $600,000, and we're adding another $150,000 to $200,000 in revenue for that practice. Mike, what do you think? Am I speaking out of my mouth, or do those numbers make sense?
No, they make sense, but I think some of what you had mentioned earlier is the ability to fill in what is called white space in schedules. Having the ability to answer, I know you used the word 1 million, probably 600 or 700 is a better number, for Monday mornings when the average industry-wide standard is people are out 15% of the time. So at any point in time, you're going to have somebody calling out. But the ability to be able to scale it to that, so that there's 750 people, digital employees answering, and in turn making appointments, which then fills up schedules, which from a medical group or hospital generates revenue. And the cost, as you indicated, is significantly lower than the human being cost.
Correct. And we do the same thing for care coordination, Mike. Every month, care coordinators have to reach out to employees. These are fairly expensive nurses. And if people have care gaps or they're on value-based agreements, it takes a lot of nurses and social workers to reach out to them. They're playing telephone tag. we take care of that for them. We don't need a nurse to be a call center operator trying to reach folks to set up appointments. Our digital employees will do that. And if there's problems, right, if while calling they find out that beyond the care gap, the patient needs other help, then they'll immediately transfer it to a nurse. So we allow nurses to give care. Why they went to school, why they are nurses. So our digital care coordinators, just like the schedulers, they're fantastic. They allow the employees to become caregivers and take care of telephone tag, take care of a very repetitive operation.
So Dinesh, you've given me a real education in terms of what you've done on a smaller scale and how it can be expanded to a much larger scale. I think this is, as we sequence additional things going from a floppy disk to a hard drive to gigs and all the other terminology, I think this is the next area that is going to be very, very beneficial, because for the most part, in this day and age with our COVID-19 issues that we've been having, with people not wanting to become vaccinated, that's their choice. But I think that we're seeing that there are fewer people available to work in healthcare operations, whether it be a hospital or a medical group or a federally qualified health center. And I think what you've done is like the next step in the process. So I'd like to thank you. Like I said, I've learned a lot today, and I certainly hope the audience has the same reactions that I have had. So thank you.
Same here, Mike. Thank you so much. It was great talking with you.
Thanks.